Maybe now, maybe it's working now. I don't know. I have to headphones. Okay, okay, now I can at least whether I can hear it or not. Wenn ich das jetzt drücke, so, kann man mich jetzt hören? Ich mache das jetzt mal alles irgendwie auf aktiviert. Mal gucken, ob das jetzt funktioniert. Eigentlich sehe ich, dass es geht. Aber wieso funktioniert das nicht? So, jetzt. Now, I think we have sound. So, let's start again. Welcome to Eurochannel. The reason why I didn't have sound, I'm going to explain. Okay. I have to deactivate this. Let's see. This. So now I hope I have some sound now. So let's try again. That's so difficult. I'm so sorry that it doesn't work. So okay, I think now we've got it. Finally, after 20 minutes. Welcome to Euro Channel, live stream with live mistakes and live problems, trying to solve the live stream problem. The reason is why this is not working.
Echo wie Sau.
Warte, warte. Okay. I still some echo problems, so I'm fine-tuning here, but at least I have some sound. And the reason why I didn't have sound was that I was doing some stuff with my software because I had a visitor today, and it was a colleague from Kiel. He is a urologist and he has a channel on Instagram. His name is Christoph van der Horst, and his channel is named Urodoc. And Urodoc is only on Instagram. So if you're watching this, I made it. I fixed the sound. So have a good trip home. So we made a video for my other YouTube channel, which is called Urologie. And this video is on German. So if you are from Germany or if you know German, then you will be able to watch it. I think I'll post it next week on Saturday. And we talked about prevention of diseases and about the concept of health and what does it mean for us doctors and what does health mean for others. If you are new to Euro Channel and haven't watched any of my videos and just happen to look into this live stream, which started as a disaster, feel free to subscribe. I can promise you my videos are better than this live stream as it started. So you may even become a member of Euro Channel. I started memberships last year. They are called the above average membership because I have a video out that's my most popular video. And this video is about the penile size. And many commented, I'm above average. So it was my idea to call it the above average membership. It's $1.99 per month and you support my work. Thank you very much. So what I wanted to talk today about is my latest video that I uploaded, which weren't that successful. I'm sorry for that, but I thought they were kind of fun and also very important information. The first video I posted on Saturday was about testosterone levels in fathers. There is some research out there that shows that fathers have lower levels of testosterone than single men who are not in a relationship, which I think is very interesting because oh, wait, I got a question. Oh, okay. Many thanks to David Len. He has posted all of the time that there is no sound and echo. Thank you very much. You made my day because without you, it would have been much more difficult to fix this here. So this thing about fathers, if you think about it, like from the standpoint of nature, why should fathers have a lower kind of testosterone? And the reason is that one explanation may be that fathers become more calm and they're not irritated by a crying child, a crying baby. So they will be more caring fathers if they have less testosterone, whereas when they want to get partners, they have to be more aggressive. And then they go out there and are more successful in mating. This concept works very well in birds. We have some data from birds that shows that this is working. And in my video, I was explaining the swan that we have on one of the ponds on our golf course, and he gets very aggressive whenever it gets April, because then he's high on testosterone and he's very protective of his territory. He attacks every golfer that comes near him, something like that. So it works in birds, but the question is, does it also work in human beings? And this may not be that simple. You know, you can't really transfer data from birds or from animals onto humans. And it doesn't make sense in a way. If you think about it, why would somebody who's in the normal range of testosterone display different behavior, and grossly different behavior from being on the lower normal level to the maybe a little higher normal level? I would say you won't be able to feel that. So I'm not quite sure if it works. And I presented a meta-analysis looking at many studies, and they concluded that, yes, there is a difference in fathers as opposed to single men when it comes to testosterone levels. But maybe the studies had some flaws in terms of statistical power and were too small to really find the difference. And if there is a difference, it may be minimal. I thought it was a very interesting study to present to you, but as I said, sadly, it wasn't a success. But that brings me to today's topic, which is testosterone, or more precisely, low onset hypogonadism. As you may know, we men don't have such a thing as menopause like women have. So they go down in estrogen when they reach a certain age, which is usually around 50 plus minus. But we men don't have that. So in principle, we have testosterone throughout our lives, and it gets a little lower, but we still stay within normal range, so it's not a problem as a rule. However, some men may get hypogonadal. Hypogonadal means that they have testosterone that's lower than normal, and they have related symptoms. So what you have to know about testosterone is that it is produced within the testicles, but it is not continuously produced. It is produced only once a day, in principle. This is triggered by another hormone, which is called LH, which stands for luteinizing hormone. This LH is produced in a little gland that's in our brain, and it's somewhere around here, just below that point. This gland gets active once a day in the early morning hours, and it releases the LH. LH is then released into the bloodstream. It travels with the bloodstream into the testicular tissue, and then it causes the testicles to produce testosterone. When we age, this may not be as efficient, or for example, if you are permanently disturbed in your sleep because of some sleep apnea or some sleep problems because you can't sleep through the night, or you are working night shifts, or you're working shifts in general and your rhythm gets disturbed every now and then, this may cause disturbances in LH release as well, so that you get low in testosterone. Most men won't feel lower testosterone levels when they are within limits, but this can be highly individualized. But what happens in most men is that sexual desire decreases when they get lower testosterone, and especially when they get into this hypogonadal state, they have lower sexual desire. And if you just lower testosterone unit after unit and you go down to like castration level, more things will happen. So when you go even lower, in addition to being very not having sexual desire, you will develop some problems with weight. So you will become more hungry, your metabolism will slow down, which means that you will gain weight. This may be one of the problems in low testosterone. The next thing is that your psyche will not work that well, so you might get signs of depression. This is why every man who is diagnosed with a depression should have his testosterone checked, because hormonal reasons may be involved in this. So if you're very low in testosterone, this may look like a depression, for example. Same goes for not being that active. So you have a tendency to take it very easy and not being active in sports or anything that you used to do. So this may be signs and symptoms of low testosterone. And then eventually it may also result in diabetes or even erectile dysfunction. But I'm kind of skeptical about erectile dysfunction because there's so many other factors that are involved when it comes to erections that just supplementing testosterone and getting men back to normal will in many cases not do the trick. At least this is my personal professional experience in the men that I've treated with testosterone because of hypogonadism and erectile dysfunction. It doesn't reestablish erections in a way that we wanted to. But we know from research that, for example, PDE5 inhibitors, something like Viagra or Cialis, has a better chance of working when testosterone levels are within normal range. So you want to get testosterone up into normal range when there is sexual dysfunction, just to make sure you're doing everything you can just to reestablish that. But as a rule, as I said, I'm kind of skeptical. And there is a new meta-analysis from the Cochrane Society, and the Cochrane reviews are very thorough and they have a high quality, and they were pooling data to look at testosterone supplement and erectile dysfunction. What they found was that it's not really working, so we shouldn't put too much hope into supplementing testosterone, which is a big problem when I look at my patients and also on YouTube. I think the effects of testosterone are grossly overestimated. So testosterone is important for men, and also when it comes to bone health and cardiovascular health, but I think we shouldn't overestimate the effects. So it's not that you are in normal range and you're a Superman, and you're slightly below normal range and nothing works. It could be in some individuals, but as a rule, I think we should just be cautious to overinterpret things into testosterone. The other video that I uploaded was part 2 of the interview with Dr. Maiken Højrup-Viborg when I was in Denmark 2 weeks ago. She is a urologist and sex therapist, as I am, and we were talking about the influence of partners on sexual function and what we can do with sex therapy to improve the sex lives of our patients. Because the partners, as you may know, are very important, because if you're alone in this world, many sexual problems wouldn't happen, because then you couldn't share it with any other person, because sexuality is something that has something to do with sociology, because there are social needs involved and there are other people involved. So it's about other people as a rule. And if you're not functioning well, you get into trouble because other people might react to that, or you might react to your expectations when it comes to other people, how you should function when you're together with other people. So, and if you don't do that, then a problem arises. Very often it helps to involve the partner. And especially if you have erectile dysfunction and you just don't tell your partner about it, which many men do. So they think that erectile dysfunction is not noticed by their partner. I really doubt that. I think it's kind of hard to not see it if you have it, But if you take PDE5 inhibitors, you may be able to do it without your partner knowing, which I don't recommend because it will not do you any good. Because as a rule, it's women who are the partners of men. And I know for sure that women want to be part of the solution and they don't want to be part of the problem. So it's always good to involve them in the process and in every therapeutic step that you want to take, because they want to be involved. This is my experience when it's a real partnership. If it's just a casual relationship, this might be different, but in a real meaningful partnership, they want to be involved. And we were discussing this construct. And with the colleague that was just here with Christoph van der Horst, I just discussed the importance of partnership when it comes to sexual function or sexual dysfunction, because there is a very interesting link between one's partner's sexual dysfunction and the other partner's reaction to that. So if one partner has a sexual dysfunction, there's a very high likelihood that the other partner might react to that with displaying sexual dysfunction. This is what this video is about, and we talked for about an hour, so I plan on uploading more about this, even though I know that's not going to be very popular, but I think this is very important content. It's how we work and what is possible by doing sex therapy, and things that we as professionals have in mind when we treat patients, and what we are looking at and how we can help patients. This may be different from your expectations. I just remember one episode when I was talking to some guy sitting next to me at the table when we were at the golf club and having dinner. Then he suddenly approached me and he was asking me, well, you are a urologist, right? And I said, yes, I am. And you're a sex therapist too? And I said, yes, I am. So he was asking me, in sex therapy, what do you do? And I think, so, well, what do you think I do? And he answered, yeah, you get undressed and the couple gets undressed and then you show them how it's done, right? And I said, no, I'm not doing that. So if you think something like that about sex therapy, you are totally mistaken. Sex therapy is totally different from that. We ask questions. This is what I do. I was educated at the Charité University Hospital in Berlin, and I learned couples therapy, which is called the syndiastic therapeutical approach. Syndiastic is derived from Greece, which means the significant other in a relationship. So it's about a couple as a patient. It's not a single person. The patient is the couple, because of what I was just telling you, that it's about people, and because people react with each other, and many problems wouldn't exist if there weren't any other people. So the couple is the patient. And this is what we do. We talk. So it's not practical that I'm involved in, but eventually the couple will start some training, which is mainly based on sensate focus, which is the therapy that Masters and Johnson developed in the late 60s, if I'm not mistaken, early 70s, which then is discussed within the setting of the sex therapy. So we talk about micro movements, if you will, to bring about changes in the expectations or the perception of sexuality, because sexuality is something to do with partnership, and partnership is a very big component. So it's not about sexual lust. It is part of that. There's also procreation, but there's also a lot of partnership. And to be able to feel things, not just saying them, but also feeling certain things within a partnership, will reestablish a strong connection. And this is the basics for everything that happens then. So I think this is a very interesting approach, and it's very important. We didn't talk with Mike and what she does, but I'm pretty sure it's quite similar. So here's the question. It's from Robert Hilversum. Is it safe to drink 5 milligrams tadalafil every day? So the dose of 5 milligram is safe. This is the dose which is developed for daily use. You know, when medication is developed, you have several stages of the development. So first of all, you have some animal experiments where you look at whether this would be able to work, and then eventually you go into human studies, and one of those steps is to find the right dosage of a medication. So you have different groups and you give them the medication and you try several regimens of what dose you will give them, so you find the right dose. So you can even give more than 20 milligrams, but this would be off-label, not 20 milligrams daily, but 20 milligrams on demand. Lately, there was a patient in my office. He had a tadalafil tablet with him. I think it was from Turkey. And it said 60 milligrams of tadalafil, which is 3 times the maximum dose which is recommended, or which is within limits that we give. I was kind of, okay, wow, that's a high dose. So obviously there are some tablets about this, but I wouldn't recommend to go over 20 milligrams. So if you take 5 milligrams a day, this will add up over the course of 1 week, which means that tadalafil is something that breaks down over the course of, I think it was 17 hours. So you have start with 100, like let's say micrograms within your blood level, and then after 17 hours it's 50 micrograms. So the half-life of this tablet is about 17.5 hours, I think it is. So if you take 1 tablet every day, or if you drink one shot every day, 5 milligrams, it will add up. After 1 week you will have a lower normal level permanently, which then will give you the opportunity to perform or have erections whenever you want and not having to take a tablet. This works for most, but not for all. So I recommend in some patients that if it's not working, you can add up 1 tablet with 5 milligrams or even 2 tablets. So depending on how it's working in the individual case. But yes, it's safe to take 5 milligrams every day. Of course, this is not medical advice. I just have to tell this to you. If you're in doubt, or if you're struggling with health problems, you have to go and see your doctor and talk to him. But 5 milligram is the recommended daily dose. And I don't think that's too much out of medical consideration to say that, because this is what's the official recommendation for this. I don't quite remember. I was in sex therapy, so I was talking about what Michael would do. I think we pretty much do the same. So we were just talking about stuff, and it sounded very similar to what I had learned. Syndiastic therapy is not merely, maybe I should say this is not merely the psychogenic approach or the psychotherapeutic approach. It's combination therapy. I love combination therapies because it gives me the best of all worlds. So I always combine this with like something like tadalafil, PD5 inhibitors, whatever works, to give the couple the security that, well, if we want to, we can change things. But I think a change has also to be brought about within the head. So it's a matter of attitude and how you look at sex and what sex means to you, and you can change that. And in many couples, this change is very beneficial because they get more relaxed in terms of sexuality, which means that if you're more relaxed, you also have a likelihood of functioning better. So it's not the aim of this therapy to make you function better. It's the aim of the therapy is about what you think about sex and what it means to you. And this change often increases overall sexual satisfaction. So this is the approach that I have and the approach that I'm practicing. Next video I will publish on Saturday. I am in the editing process. I hope it get ready, but you can be sure 2:45 Central European time, I will have a video that you can watch. It's about this little cube, maybe. So I'm trying to do a video about this little cube. Let's see. This is how it looks like. Some of you may know it. This is for measuring nighttime erections. I think this is a very interesting device because for me as a doctor, it gives me very good data on treatment progress of my patients. As you know, I'm specializing into erectile dysfunction, sexual dysfunction, and I have several treatments that I have combined or that I'm using as monotherapy, like for example, shockwave therapy. I use EMTT, which is extracorporeal magnetic induction therapy. I use PRP, which is platelet-rich plasma. I also recommend in some patients that they try radiofrequency therapy. All these therapies which are regenerative and only shock waves are somewhat in the guidelines, at least in the guidelines of the European Association of Urology. I know there's still a problem with shock waves when it comes to treatment around the world, and it's not yet approved by the FDA for the treatment of sexual dysfunction or erectile dysfunction. But here in Europe it is, and it's a recommendation in the guidelines of the EAU, which is the second largest urological association worldwide. The AUA, the American Urological Association, is the largest. So it's a large organization, and if they recommend it, I think there is some reason to do so. But maybe I should say this at this point, shock waves, I have some videos about this as well. Shock waves are not the same as radial pressure waves. Radial pressure waves are promoted as shock waves in the US very often, and there's a difference. Radial pressure waves are basically pressed air. So there's some kind of ballistic device that shoots through a tube, and it compresses air, and you get bursts of compressed air into the tissue, which behave totally different in the tissues than shock waves. These radial pressure waves are also a kind of acoustic waves, same as shock waves, but they're not sound. Sound is somewhat different. And shock waves, they come about by a specific means of production. So it's either what we call electromagnetic or electrohydraulic or piezoelectric. And with the help of these features, you get a wave that's also an acoustic wave, but that has very special features, which means that they are focused. They penetrate very deep into the tissues, much deeper than radial pressure waves. They have a high peak pressure. So it's like a tsunami flooding the cells. And then it's so strong that you have a negative pressure when the wave subsides. And this is happening in microseconds. So it's very, very fast. And it puts a lot of pressure onto cells. And this is totally different than from radial pressure waves. So we have good data on the efficacy of shock waves on erectile dysfunction. And what they do is that they increase neovascularization, which means they form new blood vessels. You get more blood into the organ, which benefits erections. The other thing is that the neural component is also enhanced, so there's the nerves work better. Then you have stem cell activation. And also something that I think is often overlooked, especially in the studies, that is muscular relaxation. Very often men tend to have an overactive pelvic floor or a very tight pelvic floor. This is what I found out by using this. I have used shockwaves now for 7.5 years, approaching 8 years now with shockwave and shockwave experience. And what I found is that if I use it on muscle, which I will when I treat erectile dysfunction, in some patients, it really has a lot of effect. And I think this is because of muscular overactivity in the pelvic floor, which is a big problem in many men. So I know there's lots of Kegel exercises out there. Men believe they have a weak pelvic floor. But if you think about it, it's a paradoxical thing that's happening. So many men have an overactive pelvic floor, which is the opposite of a weak pelvic floor. The pelvic floor may appear weak because it is overactive. How's that possible? If you just think about it, like I'll take this case here. So I want to squeeze this case. I squeeze it with maximum with my muscle, so you can see it here. This would represent an overactive muscle. If it stays in this position all of the time, if my arm would stay in this position, you would say, well, this muscle is overactive. It can't relax because it's always working. So if you want to contract this even more, it's not possible because it's already contracted at max. If you measure this plus in contraction that I could bring about with my arm, it would be very weak. It would make you think that my arm is weak because it's not contracting anymore, because it is already contracted. This is what's happening in the pelvic floor. So if you have somebody who has a very strong pelvic floor and it is overactive, and you measure that and he can't contract even further because it's already contracted, then you would have the impression that his pelvic floor is weak, while in reality it is very strong. And now imagine that on a very overactive pelvic floor or an overactive muscle, you do strength training. So something that you may be able to relate to is neck pain. Many people have neck pain and they have overactivities and they have tender spots in their neck musculature. Now just imagine you do press-ups with a neck that's sore because it's overactive, because it's hard, the muscles are contracted. It won't do them any good. So most of you guys would rush to the massage to get this softened up and not do presses because it wouldn't do you any good. It's the same with the pelvic floor. So if the pelvic floor is overactive, the least thing that you would want to do is to even strengthen it more. It would weaken it more, and it wouldn't do your erections any good. Therefore, you should try to do relaxation exercises for your pelvic floor. But however, there are exceptions. Not every man has an overactive pelvic floor. So I palpate pelvic floor on all of my patients. It's something that I do as a urologist because I have mostly men and I want to have an impression of the prostate. So I do pelvic floor palpation as well. There are many men who have normal pelvic floors, but if we look at the proportion of having an overactive pelvic floor or even having a weak pelvic floor, the men who have an overactive pelvic floor are far more than those who have a weak pelvic floor. Weak pelvic floors are very prevalent in men who are older and like in senior age. You have passed 70 years of age. There's a likelihood that you have an overactive not an overactive, a weak pelvic floor, or you went through prostate surgery, especially if we're talking about prostate cancer. You get your prostate removed, your pelvic floor is weak. That's a fact. So these guys need pelvic floor strength training. They need Kegel exercises. But I caution to do Kegel exercises just because you think you have an overactive pelvic floor. I really advise you to go to somebody who knows how to assess a pelvic floor. That's typically a physiotherapist who is trained in pelvic floor matters, and they will be able to tell you whether your pelvic floor is overactive and whether it would be a good idea to do Kegel exercises. Otherwise, I'm very skeptical and I won't recommend it. So Mark Grayson is asking, Hmm. It's about it's a totally other topic. It's about urethral strictures. Urethral strictures is a big problem in urology. The urethra is a tube that connects to the bladder, so the urine that gets out has to travel through the urethra. So it's a tube. The problem is tubes that have damage get scars, and scars, they will contract. So a tube that has a caliber like this and it has some kind of damage will get a scar that will make it go like this. This is what we call a stricture. That's a big problem because now the urine can't travel freely anymore, and it will lead to several problems with the bladder and the whole urinary system. If you operate this and just cut it open, it may stay open, but there's a very big likelihood that it will regrow into a scar that then will get narrow again. So it's a really nasty thing to have, and it's a chronic thing. And if you're lucky, you can get away with some operations, but many patients, they struggle with this for many years. And you can do plastic surgery, which means you open up the urethra and you just remove this part which is scarred, and then you replace the scar tissue with buccal mucosa, which is something that you take from here, from the inner portion of your lip, which you then put together as a replacement, which works in many patients. But even here, I've seen restricturing in these patients, and that's too bad. Now you had an open operation, it doesn't get better. It's a real problem. So the question is, what about placing a stent, or even if it's a distal stricture, which means that it's close to the opening of the urethra, why not place a stent? And a stent is a small tube that you can insert here, and usually it's constructed of like a spiral, and there are some materials that really get soft. So if you insert them, they get flexible and they're not that stiff. But stents, they're not the holy grail, I have to say. Stents have been around for decades, but once in a while they have a revival, but they're not going to stay. So they disappear, and then after a couple of years they come back because they're really not that thing that you want to do. Stents have a tendency to migrate. That's the biggest problem, because the penis is not static, it's a dynamic organ, so it expands and shrinks, and so is the stent. So it can migrate, and then it gets out of place, and it's a real problem. So it's not working. Yeah. So next question, I hope I answered this sufficiently. Fabian Alejandro in Argentina. Thanks a lot. Thanks a lot for your positive support. I really appreciate it, because it's like sitting in the middle of nowhere here. So I just hear my own voice, and it's a funny feeling to sit in front of the camera. So I'm just seeing the camera here and not knowing who's on the other side of the camera. So if you like my content, thank you very much. I'm very pleased that you do. And you also wrote something very nice, but it's not the whole story here. So I'm pleased that you like my content. Okay, I was just finishing off this little sensor here. So you can mount it and it stays on. Of course, I tried that myself, and to my surprise, like, imagine having this thing. It looks kind of large, doesn't it? So you would think that you can't sleep with it, but it was really no problem. And I even could go to the bathroom with it. They recommend that you just take it off. I have to say, I was so tired, I didn't do it. I just went to the bathroom and it worked. So it gave a report, and in this report you get how many minutes you have erections and the episodes of erections during that night, and even the quality of the erections. And I think this is brilliant when it comes to research. So now we have the opportunity to do research with that thing and get more information about whether treatments work. Like if I do combination therapy with PRP, ESWT, EMTT, I would really get some control over what's really happening, because sometimes it may work, but the patient may tell me it's not working. Sounds funny, doesn't it? But I've had these cases where I clearly had the impression that my therapy was working. Like for example, for erectile dysfunction, patient was telling me it wouldn't. But how do I know that I think it was working? Simply because when I was doing shockwave therapy, the patient would get a small erection, so not a real erection, but the penis would react to the shock waves. And then I would think, well, if it's reacting to shock waves, how couldn't it react to sexual stimuli? So it wasn't a sexual stimulation in this way, but it was just reacting to the mechanic hitting the penis with shock waves. So this thing would really help to distinguish between something that's maybe a psychogenic problem, because it's maybe something that's related to the partner. So if it's working like in a clinical setting, which is non-erotic as it can be, and it's not working in an erotic situation, maybe there's something that's related to the partner, or something that's related to the perception of what's going to happen. And this sensor would clearly help to distinguish between that. And the advantage is that before that, there are machines to help measure that, but these are not very much available, at least not in this part of the world. They are for rent. There's a company who rents them out, which is terribly expensive, the old machines. They come from America. And the funny thing is, they even charge more for doing the report. And I was thinking, well, I could do the report them myself. I could just hook it up to my computer and then I can just look at it. And they said, yes, you may be able to do that if you have a computer with Windows 95. So it's something that's 30 years old. Nobody has that anymore. I think I may have one computer with Windows 95 on it, but I'm not sure whether it's still working. So this is the old machines. But the new ones, you get your report on your smartphone. You can look at it yourself. So my conclusion is, do you need this? I think if you're a health tracker and you are in rejuvenation, it might be a good thing to have a look at it. And if you're interested, it's fun. So you can go to your friends and say, hey, I'm 22 years old. I'm 60, but my penis is 22. It's a possibility. But if for life, I'm not quite sure if you need it. So only if you're interested, because it costs some bucks here. So it's not for free. Very interesting gadget. So I'm going to do a video about it tomorrow, hopefully. So what's the time? So I've been talking over half an hour. Thank you very much for your patience, especially in the first 20 minutes of my live stream where you couldn't hear anything. I'm not quite sure how I do this on YouTube, because people may just switch off the live stream when they don't have any sound. But we'll see what happens. Maybe I re-upload it as a podcast because I'm also recording this live stream, so I may re-upload it not as a live stream but as a podcast. See you next week if you want. I would be pleased if you just switched on your computers or looked at your smartphones, 8 o'clock Central European time, as always, and I will be streaming. Have a good night. Have a good weekend. Bye bye.